Hi, this is Neelish Patel, and I'm giving the first in a series of lectures for the Duke Night curriculum. It's part of the bigger Back to Basics curriculum, where we're really focusing on things that you may see in the middle of the night. So the goal is to have a series of lectures on topics that are particularly useful, are clinically practical, and are relatively short in helping you manage patients that you may see overnight. So the first in the series of these lectures is an approach to hypoxia. It is the first time that we're doing one of these lectures, so if there's something that you think that we can use to make this project better, please feel free to email me at neelish.patel.duke.edu, and of course if there's any questions or concerns, please feel free to email me as well. So this lecture will have two major objectives. First, to create a framework in which to think about the differential of respiratory failure, and then second, to understand a few concepts in the acute management of respiratory failure. So how do we start by coming up with a differential? And one way to think about it is how can we use the AA gradient in order to think about a differential for hypoxic respiratory failure. So someone's not doing well, you can ask yourself, does the patient have a high AA gradient or not? And why is that useful? So the AA gradient is the difference between the alveolar O2 and the arterial O2. The formula for it is relatively complex because though an arterial O2 is easily measurable by an EBG, the alveolar O2 is hard to assess. You use the alveolar gas equation to estimate it. And the alveolar gas equation is dependent on a few factors. The ones I want you to pay attention to are the FiO2 and the PaCO2. The rest adjusts for the elevation that you're at and the amount of oxygen that you're at, which is the FiO2. So at room air and at sea level, this formula simplifies to 150 minus 1.25 the PaCO2, or the arterial CO2. But the things that are particularly useful in that formula are that if someone has an increasing FiO2, the PaO2 increases. So another way to think about this is that if you're requiring a higher level of oxygenation in order to maintain an arterial saturation, you have a higher AA gradient. What does that tell you? That there's something wrong in this alveolar capillary unit that's driving the problem with the patient's respiration or respiratory status. So a normal AA gradient is 4 plus the age over 4. So in a 40-year-old patient, this would be about 14. If you have a wide AA gradient, it tells you that there's something wrong in the alveolar capillary unit in the patient. If you have a normal AA gradient, there's something else that's driving this hypoxic respiratory failure. And those things are issues where there isn't a problem with this unit, but rather an issue with ventilation, like hypoventilation. So the AA gradient helps you differentiate factors that are problems with the alveolar capillary unit or those that aren't and are more problems with ventilation. So what are causes of a high AA gradient? And we'll talk about things like shunting and diffusion impairments and VQ mismatch. So VQ mismatch is the most common cause of hypoxic respiratory failure. Everybody has a difference between ventilation and perfusion in normal lungs. V for ventilation, Q for perfusion. Blood flow normally is greater at the bases of the lungs because of gravity, so you have a higher perfusion at the base of the lung. So this ratio of ventilation to perfusion is lower because the denominator is larger. At the apex of the lung, you have less perfusion, and so that ratio is higher. And that's normal in all individuals. So there is some VQ mismatch in all lungs, but when that is out of proportion to maintain oxygenation is when you get hypoxic respiratory failure secondary to VQ mismatch. And there's extremes of this. So dead space refers to where there's high amounts of ventilation, so air is reaching alveolar is reaching through the airways to the alveolus, but there's no perfusion of blood flow. Shunt is also an extreme of this. We often talk about it separately, but it is just one extreme where there is no ventilation to blood flow. That's important to keep in mind because we often think of anatomic shunts, which we'll talk about, but there's also physiologic shunts. So, what causes a worsening of this ventilation to perfusion ratio? What causes more of a mismatch? So there are two particular things. So if oxygen is limited in the airway, say COPD, where chronic bronchitis limits the amount of oxygen that can reach the alveolus, there is less oxygen here compared to a normal alveolus. Similar things that can do this are problems with alveolar filling. Pneumonias and edema take up a portion of this alveolus and also lead to decreased O2. So if you have an area that has decreased ventilation, so less V2, compared to blood flow, you have more of a mismatch compared to normal areas of ventilation. So if there's less ventilation, the blood flow isn't as oxygenated well, so you have mixing of well-oxygenated and not well-oxygenated blood flow, which leads to decreased O2 in your vasculature. PEs can do the same thing, where there's limitation in blood flow. So now you have a distinction between blood flow and ventilation limitations. When there's a PE, your ventilation essentially drops to zero. Your perfusion drops to zero, but your ventilation remains normal for the most part. There's some theories that there's actually local collapse of airways. So you have areas of high VQ compared to normal VQ. That mismatch is still what leads to hypoxia in PEs. But remember, even though there is a limitation in oxygenation, there is still O2 reaching the alveolus. So this does respond to oxygenation. This is not a complete limitation in O2 reaching the lungs. Shunt, there's no ventilation to blood flow. So this can be a direct right to left shunt, so mixing of arterial and venous blood, or it can be a physiologic shunt, where edema, pneumonia, or other causes of alveolar filling lead to no O2 being able to reach the alveolus, and then there is no oxygenation of the blood flow to that alveolus. No matter how much you increase that O2, there is no way to overcome that. So it does not respond well to oxygen. You manage it by recruiting more alveoli and increasing blood flow to areas that are well oxygenated. Causes are anatomic shunts, filling defects, or complete alveolar collapse like atelectasis. And the last one we'll talk about is diffusion impairment. This isn't in either scenario truly, but some kind of interstitial disease, fibrosis or otherwise, that leads to a diffusion of impairment of O2 from the blood to the vasculature. Now, if you have a normal heart rate, there's enough time for O2 to go from the alveolus to the artery. If you don't, if you have increased heart rate, that's when you'll see this hypoxia. You won't see it at normal heart rates. And the last thing to talk about is when this unit is normal, but you still have hypoxia, and you have a normal AA gradient, and you'll also have an increased PaCO2, that is because of hypoventilation. Normal AA gradient, hypoventilation. Increased AA gradient, a problem with the pulmonary capillary unit. So a good initial way to think about it, about hypoxic respiratory failure. When I'm evaluating my patient, is there something wrong with my patient's blood flow to the lungs themselves, which would cause a high AA gradient, or is it because the patient is not ventilating appropriately, which would lead to normal AA gradient. Manage these very differently. As a summary, BQ mismatch, high AA gradient, responds to O2. Causes include COPD, low amounts of filling defects like pneumonia and edema, or vascular problems like PEs. Shunts do not respond to O2 and are an extreme of BQ mismatch in reality. They can be anatomic, they can be full filling defects, so severe pneumonias or edema, or can be alveolar collapse like atelectasis. And then diffusion impairment. Normal AA gradients with an elevated PaCO2, you think about hypoventilation. You can also get hypercapnia with respiratory failure and a wide AA gradient. That's when you have dead space ventilation. So that isn't hypoventilation, that's ventilation of dead space. So now you have a differential in your mind. Is this a lung problem? Is this a ventilation problem? How do you start management? You want to start the patient on some oxygen. A nasal cannula at 2 to 6 liters can get you an FiO2 of 25 to 45%. Another step, you can put a simple face mask on a patient. You never want to start below 5 liters. A face mask goes over a patient's mouth and has holes in it to allow circulation of ambient air. So even at high flow rates, you don't get a very high FiO2 because it's mixing constantly with ambient air. But you don't want to go to low flow rates. And the reason you don't is because if you don't have high enough flow, you don't push that CO2 out, and patients will start rebreathing CO2. You want to keep that in mind when you're thinking about a non-rebreather as well. This has an oxygen reservoir that can help patients get higher FiO2s, and you can deliver an FiO2 of greater than 60%, but you want to make sure that the reservoir never deflates. And the reason you want to pay particular attention to that is if the reservoir deflates, you're just recirculating that CO2. And if you need to titrate that O2 very closely at the patient's bedside without a ventilator, then you can use a Venturi mask and titrate a fixed FiO2, and you can titrate from 60 to 100% on the Venturi mask as well. So now, you've worked on oxygenation, and the patient is receiving more oxygenation, right? And these are for the most common causes of hypoxic respiratory failure, those that will respond to O2 at the bedside. You also want to start reversing the causes of this. So if this patient is presenting with respiratory failure secondary to heart failure and have a lot of pulmonary edema, then you can diurese them. You can do the same thing for non-cardiogenic pulmonary edema. You can give them an IV dose of diuretic, but you really want to reevaluate them within the next few hours and make sure that their urine output has responded adequately. If it hasn't, that's when you need to either give them more diuretic or think about other ways to manage them, which we'll talk about in just a second. For things like PE, and if that's what you're concerned about, you can consider placing them on anticoagulation. And then for things like aspiration or pneumonia, whether it's related to aspiration or not, you can start antibiotics. Throughout this process, one thing you want to keep in mind is, are they at the appropriate level of care? If their oxygen needs are going up, if you're putting them from a simple mask to a non-rebreather, then you really need to worry about whether they're continuing to be stable through the floor and whether our level of nursing can support what they need. The next step you want to think about